Okay, guys, welcome to part two of the breast cancer case presentation for your final year practical exams. So, in the first part, we spoke in depth about history, examination, and workup of a patient who presents to you with suspected breast cancer. Now, the second part, we'll discuss the management of various subtypes of breast cancer. Um, so, we'll start off with hormone positive breast cancer. Now, for hormone positive breast cancer, not all patients require intensive treatment, right? Hormone positive breast cancer tends to have a better prognosis than the triple negative and HER2 positive counterparts. So let us look at that particular case. If you didn't watch my last video, you can go and watch part one. So that was a T4N1 hormone positive case. Now, given that, how would we treat this patient? Not to mention, she's a 42-year-old premenopausal lady, right? So the treatment of choice in this particular patient will be, since she's locally advanced, right? So the definition of locally advanced, uh, to put it quite mildly, is stage 1 and stage 2 disease is considered to be early breast cancer, and T3N1 in stage 3 is considered by some to be early breast cancer as well. But for the most part, stage 3 and stage 4 disease is stage 3 disease is considered to be locally advanced, and stage 4 is considered to be advanced disease, right? So when you deal with a case of locally advanced hormone positive breast cancer, they're the treatment of choice. Like I said, in all patients that have a disease that is more than T3 or more than N1, right? You tend to give neoadjuvant treatment in hormone positive breast cancer. If it is up till T3 or up till N1, there you can go for upfront surgery. So that is the scenario in breast cancer. Up till T3 or N1, you can go for upfront surgery. If it is more than that, you go for neoadjuvant treatment in hormone positive breast cancer. Okay, so this particular patient is T4N1. There we like to give neoadjuvant chemotherapy. And since she is a young patient, 42 years old, so any patient hormone positive that is, less than 50 years of age that warrants chemotherapy, in this case it's a locally advanced case, there we'll give dose dense chemotherapy, right? So we'll give dose dense AC into 4, followed by dose dense Paclitaxel into 4. So that's dose dense AC every 2 weekly, followed by dose dense Paclitaxel every 2 weekly, right? Following that, we'll do surgery, right? Surgery can be in the form of breast conservative surgery or MRM, combined with, an axillary lymph node dissection. And then we'll proceed to give radiation. We'll talk about all the indications there. This particular case, there's upfront T4 disease and N1, so radiation is mandated here. And following that, we can give hormone therapy plus OFS. And in this case, since it's locally advanced, we can give adjuvant CDK4/6 inhibitors. And you can also combine that with, right. So, I mean, that is enough. Hormone therapy plus OFS plus adjuvant CDK4/6 inhibitors, right? So that is generally what we tend to give for this particular patient. So now let us look at all the different components of the treatment that we have now outlined, right? So first is neoadjuvant chemotherapy. We'll give dose dense AC into 4 every 2 weekly. So the examiner will ask you at this point to outline the chemotherapy protocol, right? So dose dense AC, the pre-medication will include, since this is a highly emetogenic chemotherapy regimen, we'd give a pre-medication of Emisset 8 mg, Dexa 8 mg, right? You'll give your NK1 antagonist, so you can give either aprepitant 125 mg day 1, 80 mg day 2 and day 3, or you can give fosaprepitant 150 mg over 30 minutes, right? And then you would start off with your chemotherapy. So that will include adriamycin, injection adriamycin, or a doxorubicin given at 60 milligram per meter square in 100 ml NS over 15 minutes, or in certain protocols, in certain settings, people tend to give it as an IV bolus, but even 15 minutes is fine. We give adriamycin first of all because it is a strong vesicant, and like all vesicants, we need to be careful when administering it, and we give it as the first agent, when the IV line is fresh. Following that, you'll give injection cyclophosphamide. Injection cyclophosphamide is given 600 milligram per meter square over 15 minutes IV in 100 ml NS, or you can give it as an IV bolus. In certain institutes, it is given like that, right? Post-chemotherapy medications will consist of antiemetic medications. So you can give injection DEXA 4 mg BD for 3 days with PAN 40 mg OD for 3 days. You can also consider adding olanzapine 5 mg OD for 3 days as well. So that is how I'd like to give your dose dense AC. Another thing I would like to add here is that since dose dense AC has got a high chance for febrile neutropenia, greater than 20%, I'd also like to add primary prophylaxis here. Okay. Now, at this point, various things can be asked regarding your dose dense AC, okay, that you need to be prepared for. Number one here is regarding the cardiotoxicity of adriamycin, right? Like we all know, adriamycin causes irreversible cardiotoxicity, and there are various ways in which we can take precautions to prevent the cardiotoxicity of adriamycin. So what do we do? At the baseline, we should do an ECG. And as we outlined earlier, we should do an echo with a GLS score, a global longitudinal strain score, right? And if that is not conclusive, we can also do a cardiac MR, right? A cardiac MRI can be done for further and better characterization of the ejection fraction. So those are some of the tests you can do. You can also use biomarkers, right? Like TROP-T and brain natriuretic peptide levels. That can also give us an idea regarding future cardiotoxicity for that particular patient by doing it at the baseline, right? So now, how do you monitor during treatment? Generally, you do an echo at the baseline, right? And here we're giving a cumulative dose of 240 milligram per meter square. So further monitoring during treatment in a patient with normal ejection fraction is not required. So that brings me to the Schwartz protocol. The Schwartz protocol says that if the ejection fraction at baseline is greater than 50%, then LVF assessment should be done at baseline, and following that, it should be done after 250 milligram per meter square of doxorubicin has been given. Since we are only given a cumulative dose of 240 here, it is not required. Further monitoring is not ideally required. So now 30 to 50. Here also, as per the Schwartz protocol, you can consider giving doxorubicin, but you need to do cardiac monitoring with every cycle, right? And during monitoring, if there's a fall greater than 10% of the ejection fraction greater than 10% fall with the ejection fraction being less than 30%, you need to discontinue doxorubicin. So that is the Schwartz protocol for monitoring of doxorubicin. Now, apart from this, what are the ways in which we can reduce the cardiotoxicity of adriamycin, right? So a lot of these are not practical, but theoretically speaking, the examiner can ask you, what are the ways in which you can reduce the cardiac toxicity of adriamycin? So these are some of the ways that come to mind. So you can consider giving a weekly regimen. You can give a slow, continuous infusion that can reduce the cardiotoxicity. You can give an alternative anthracycline derivative. So there's a drug called epirubicin, which is given at a dose of 100 milligram per meter square that can be given instead of adriamycin. The advantage here is that adriamycin has a cardiotoxic cap dose that is of 450 milligram per meter square. So beyond that, the chances of severe cardiotoxicity go greater than 5%, right? So that is a cap for adriamycin. But for epirubicin, that cap is at 850 milligram per meter square. So it's got less chances for severe cardiotoxicity because the cardiac cap is higher. Now, another advantage is less myelosuppression, right? Less mucositis and less nausea and vomiting. So less nausea and vomiting, myelosuppression, mucositis, and most importantly, less cardiotoxicity. So epirubicin, which is an epimer of adriamycin, is a good substitute for that. Now, of course, you can also add other agents like such as ACE inhibitors, ARBs, beta blockers, statins, and diuretics. The examiner might ask you for trials and evidence for this. So you can say carvedilol. There's a PGH Chandigarh trial which shows less cardiac toxicity. You've got the Prada trial which looks at candesartan, which shows less cardiac toxicity with the addition of that drug. Then you've got the Elevate trial which looks at eplerenone, which shows reduced cardiac toxicity by the addition of that diuretic. So those are some examples of other agents that you can give to reduce the cardiac toxicity. Now there's another agent which is called dexrazoxane, which is an iron chelator. So anthracyclines, they interact with iron, and the combination of iron and anthracycline acts as a free radical and leads to lipid peroxidation of the cardiomyocyte membrane, thereby leading to cell damage. But dexrazoxane is an iron chelator which prevents the formation of that anthracycline iron combination, right? So that is how we reduce cardiac toxicity. So that can be given at a 10:1 ratio. So if you're giving 60 milligrams of per meter square of doxorubicin, you should give 600 milligrams of dexrazoxane. That should be given 15 minutes prior over in a 30-minute infusion, right? So in a 10:1 ratio. And basically that is not approved in the radical setting, unfortunately. That is just a theoretical thing. It is mainly approved in the metastatic setting in trial data. But that can be tried in certain scenarios, right? So that is another theoretical, but not really a practical option. So those are some of the ways in which we can mitigate the cardiac toxicity of anthracyclines. Now let's look at extravasation. This is very commonly seen when we deal with our chemotherapy patients, and we should know exactly how to manage it. So anthracyclines can cause severe extravasation, right? They are DNA binding vesicants. So once the drug is extravasated, what do you do with the patient? So extravasation is something that we need to talk about. So once the drug is extravasated, you need to keep the cannula in place and aspirate as much of the drug as you possibly can. Once you've done that, you mark the area of extravasation, you remove the cannula, making sure that the arm is raised, and then you apply your cold compression. Since it's a DNA binding vesicant, the drug needs to be localized and neutralized, right? So you apply cold compression for around 20 to 30 minutes, 4 times a day for 2 to 3 days. Okay. And following that, you can also give DMSO. Now, DMSO is given in a 99% concentration, right? And it is given 4 drops per 10 centimeter square surface area, and should be given to double the area than that in which the extravasation has occurred. So that is how you give DMSO. Now another agent that is commonly asked, you'll score extra points for this, is once again dexrazoxane. So dexrazoxane can also, mitigate the effects of extravasation in doxorubicin. Here you give it at a dose, you should give it within 6 hours, and you should give it at a dose of 1000 milligram per meter square, day 1, 1000 milligram per meter square, day 2, and 500 milligram per meter square, day 3, right? So this is how you give dexrazoxane in extravasation with doxorubicin. Okay, so these are some of the precautions that one needs to take when you give AC, especially anthracycline precautions one should be aware of, right? So we spoke about how to give that regimen. Now moving on to dose-dense paclitaxel. Paclitaxel is given in dose-dense forms in 2 methods. There are 2 ways to give dose-dense paclitaxel. That is, you can give it 175 milligram per meter square, 2 weekly, which is dose-dense 2 weekly paclitaxel, or you can give it weekly at a dose of 80 milligram per meter square, and that can be given weekly into 12 cycles. So these are the 2 forms of dose-dense paclitaxel. There is 2 weekly into 4, and there's also 12 weekly. So 2 weekly is 175 milligram per meter square, 12 weekly is 80 milligram per meter square. When you're giving it at 175 milligram per meter square, this is the protocol. So you give your Avil, Rantac, Emisset, right? But prior to giving all of that, 12 hours prior to giving paclitaxel, you should give Dexa 20 mg. 6 hours prior to giving paclitaxel, you should once again give Dexa 20 mg. And then on the day of paclitaxel, you give Avil, Rantac, Emisset, Dexa 8 mg once again, and then you give paclitaxel. Now, the way to give paclitaxel is over 3 hours in 500 ml of NS, and you should use a non-PVC bottle because PVC, it interacts with paclitaxel and causes leaching of plasticizers, especially plasticizers like DHP. So that can cause severe reactions, right? Also, paclitaxel contains chemophore, which is a preservative. That can also cause severe hypersensitivity reactions. So to prevent that, you use a codon set, which is a 0.22 micron filter, which filters out the chemophore and decreases hypersensitivity due to the preservative, right? So non-PVC bottle to prevent plasticizer leaching, and a zero point 0.2 micron codon set to filter out the preservative, which causes hypersensitivity. So that is given over 3 hours, and that is the protocol with that, right? So you can also give it 12 weekly, 80 milligram per meter square. That is also a dose dense protocol, but here you need not give the pre-medication 12 hours and 6 hours beforehand. But once again, you need to use a codon set and a non-PVC bottle, right? So that is the regimen. Now coming to surgery. So surgery here, you need to know that both MRM and BCS are viable options. So the decision between both depends on a multitude of factors, including patient preference, right? So patient preference is important, but not all cases can be taken up for breast conservative surgery. So breast conservative surgery is contraindicated. You should know the contraindications. So some of them are inflammatory breast cancer. If you have diffuse suspicious malignant appearing microcalcifications that cannot all be excised with conservative surgery, or if there's an inability to obtain positive margins despite repeated wide local excision, and patients with gestational breast cancer who cannot receive RT within the first trimester, right? So they're also avoid breast conservative surgery. And of course, other relative indications are the patient has received prior RT, because we know we need to combine breast conservative surgery with radiation, right? Or patients who have multicentric disease, patients who are BRCA mutated because they have higher chance for other ipsilateral tumors, contralateral tumors as well. So all of these reasons, or patients with, skin autoimmune conditions, all these are relative indications. And combined, these are the indications for avoiding breast conservative surgery, right? Um, now, now, in this particular case, we'll go for an axillary lymph node dissection because it's a hormone positive case and it is node positive, and we have gone for a neoadjuvant treatment, right? So here we go for a full-on axillary lymph node dissection. Now, before getting into that, let me also remind you about what it means to attain negative margins in a breast cancer case. So if you are doing BCS or MRM, for especially BCS, the negative margin, you mean you the negative margin is defined by the absence of tumor cells at the inked margin. So at the inked margin, there should be an absence of tumor cells. So that's when you say you've obtained negative margins in a breast cancer case who has undergone BCS, right? So I've outlined the contraindications of BCS. I've outlined what an adequate margin means, and axillary lymph node dissection as well in this case, because we have given NACT and it is in a locally advanced case, right? Okay. Now, I'll quickly before we get into that, we'll quickly go into radiation. So just to break it down to you, right? In all cases of breast conservative surgery, you need to give adjuvant RT, right? And that is given at 40 gray plus 15 fractions. And so you give adjuvant RT to the whole breast in breast conservative surgery in all cases, plus cavitary boost. So this is called hypofractionated RT to the whole breast, cavitary boost. So the boost is given at 10 to 16 gray, and that is given at 2 gray per fraction, right? 2 gray per fraction. Okay, so this is what you do in all cases of BCS. Now, in cases of MRM, right? In cases of MRM, you tend to give, so all cases of BCS, you need to give radiation and a boost. In MRM, you give adjuvant radiation if the patient has received neoadjuvant treatment and had clinically T3, T4 disease at the baseline, or was clinically node positive N1 or more, or pathologically if the patient has T3, T4, or if pathologically the patient has greater than N1 disease. So these are the indications for adjuvant radiation post-MRM. Now, right. So now that we have established that, of course, when you come to radiation, right, also need to consider you also need to consider irradiating other areas that can be involved, right? So sometimes you have to, more often than not, you have to irradiate the SCF if there was clinically N1 disease or pathologically N1 disease, right? So whether that's BCS or MRM, you need to irradiate the SCF as well if there's clinically N1 disease or pathologically YP or otherwise N1 disease post-surgery, right? Um, so that is another indication that you need to think of. Okay, so now that we have looked at irradiation, let's move on to the last part of treatment for this particular patient. So it is hormone therapy. Now, hormone therapy is given in two ways, right? So let's look at the ways in which hormone therapy is given. If you're giving it as tamoxifen, you'll give it for 10 years. We have got the ATOM and ATLAS trial, which shown that there's a benefit of giving it for 10 years over 5 years. There's an OS benefit. Another option is to give AI. I know this is a premenopausal patient, but AI can also be given in this case, either letrozole or anastrozole can be given. That is given for a period of 5 years. And you can extend that to 10 years. We have trial data in the ARIS trial as well as the NSA-BP42 trial, which has shown that there is some benefit of extending up to 10 years for locally advanced cases and for example, T4 disease or N2 or N3 disease, right? So you can consider extending to 10 years. Now, of course, since this patient has high risk features, this patient also warrants OFS, right? Now, one point to add here is that you will only start the patient on AI inhibitors in a premenopausal patient. You will only start them on AI inhibitors if you're giving concurrent OFS or if the patient is in a premenopausal state by looking at the FSH and estradiol. So you should always give OFS if you're giving AI in a premenopausal patient, and you should make sure that they're in a postmenopausal state while starting off with AI, right? Now, OFS is given in the form of triptorelin. It's given in the form of goserelin, right? So triptorelin is given at a dose of it's given every monthly, right? And it is given at a dose. So we have got triptorelin and goserelin that are approved mainly as treatments, as OFS agents. And let's look at the doses of these agents, right? So triptorelin is given at a dose of 3.75 milligram IM, and goserelin is given at a dose of 3.6 milligrams subcutaneous, right? So these are the two approved OFS agents. Other methods of OFS include radiation at a dose of 10 to 15 gray, and also bilateral salpingo-oophorectomy, although that is radiation and oophorectomy are irreversible ways of giving OFS. So we generally tend to give it for 3 to 5 years. Now, where does the data come from? We base it on the soft and the text trials. So the soft trial, so the combined analysis of both trials show that there's a benefit of giving OFS along with your hormone therapy, in patients that have age of less than 35 years, patients who warrant chemotherapy, grade 3 tumors, and if the size is greater than 2 centimeter. So these are risk factors for which OFS, with which patients might benefit from OFS, right? And the combined analysis looked at three combinations. So tamoxifen alone, tamoxifen plus OFS, and AI plus OFS. And what they found was that there was a 7% benefit of giving AI plus OFS over tamoxifen, and there was a 5.4% benefit of giving tamoxifen plus OFS over tamoxifen. So wherever possible, try to give AI plus OFS if there are high-risk features, like I outlined earlier. If not, give tamoxifen plus OFS, and if not required, you can give tamoxifen alone if there are no high-risk features, right? So another part of the adjuvant treatment here is, the addition of CDK4/6 inhibitors. So that has come into the foray right now. So two agents are approved. One is abemaciclib, right? So that is based, abemaciclib, right? So that is based on the Monarch E trial. And so abemaciclib was given in high-risk patients in the Monarch E trial, and that was given for around 2 years at a dose of 150 mg BD, right? And in that particular trial, so 150 mg for 2 years, right? And then in that particular trial, they found that abemaciclib increased the DFS by around 7%, absolute benefit of 7%, and increased the overall survival as seen recently by up to 2%. And that was, the benefit was largely seen in patients who had 4 or more positive nodes, or if the patient had 1 to 3 positive nodes with grade 3 disease or with size of tumor greater than 5 centimeters. Earlier, Ki-67 greater than 20 was also another feature where abemaciclib could be given, but that has now been removed. So 4 or more nodes or 1 to 3 nodes with grade 3 or size greater than 5 centimeters, you should give abemaciclib for 2 years in hormone positive patients. Another option that is there is ribociclib. So this is based on the NATALEE trial, right? So ribociclib, and this is given for 3 years at a dose of 400 mg OD for 21 days out of every 28 days, and that is given for 3 years, right? So the usual dose of ribociclib in the metastatic setting is 600 mg, but here it is given at a dose of 400 mg OD 21 out of every 28 days for 3 years. And that is based on the NATALEE trial, which has shown an IDFS benefit of giving ribociclib at 5 years, right? So the OS data is still pending. So these are 2 FDA approved options. Now, if the patient is germline BRCA positive, there is another option here. So if the patient is germline BRCA positive, we can also consider giving olaparib. Now, olaparib is based on, so giving olaparib is based on the Olympia trial, right? So the Olympia trial has shown that if you give adjuvant olaparib in hormone positive and triple negative patients in certain with certain risk groups, there is a DFS and OS benefit. So hormone positive patients, what are those risk factors? So if the patient has received NACT, right, the patient should have no PCR plus a CPS EG score of 3 or more, right? So CPS EG score of greater than or equal to 3. CPS means clinical, pathological stage, as well as ER status and grade. So all these factors, the score is 3 or more with no PCR post NACT, you can give olaparib 300 mg BD into 1 year. And another thing to note here is if the patient underwent upfront surgery and is receiving adjuvant treatment, there the criteria to give in hormone positive as per the Olympia trial is 4 or more nodes positive, right? So pathologically 4 or more nodes are positive. There also you can give olaparib. So one more thing to note here is that adjuvant olaparib should be given post radiation, right? It should not be combined with radiation. And another thing to note here is that they'll ask you about the side effects, right? So let's go over the side effects of these adjuvant agents. Abemaciclib is a CDK4/6 inhibitor, but the main toxicity is diarrhea here. Ribociclib, the main toxicities include myelosuppression, LFT derangement, fatigue, anorexia, nausea. It can also cause QTC prolongation and severe cutaneous adverse effects, right? With olaparib, of course, the feared toxicity is AML, MDS, but in the Olympiad trial, they found that it was less than 1%. So although it is there, the incidence is very low, but it can cause anemia, it can cause myelosuppression, it can cause diarrhea, GI side effects, and it can rarely cause ILD. So these are the top things that we need to be aware of. Now, there is another thing that we can add if the patient is postmenopausal. This patient is premenopausal, but for all postmenopausal hormone positive patients, regardless of their stage, we can also consider adding bisphosphonates, right? So bisphosphonates can also be considered. This is based on the EBCTCG 2015 meta-analysis, which showed an OS benefit of adding zoledronate for 3 to 5 years every 6 months in postmenopausal patients of breast cancer. So all breast cancer patients, regardless of subtype, who are postmenopausal, regardless of stage, you can add zoledronate or any other bisphosphonate as shown in EBCTCG 2015, and it leads to a decrease in breast cancer mortality. So it decreases the metastasis that is induced by osteoclasts which secrete various factors that enable metastasis, right? So that is the proposed mechanism of action. So that is another adjuvant treatment. So yeah, so these are the adjuvant treatments. Of course, olaparib only if you have germline and BRCA mutation, right? Now, before we move past hormone positive, there are other scenarios that I'd like to talk about. So not all hormone positive patients require chemotherapy, right? We have something called oncotype. Right. We have something called oncotype DX, right? So this is a 21 gene PCR based testing, which looks at whether early breast cancer patients require treatment or not. So moving away from this particular case, if you get a T1 or T2 lesion, or if you get a T1 to T3 N1 lesion upfront and you have done upfront surgery, not all hormone positive patients require chemotherapy. So you have two trials, the Taylor X trial and the Responder X trial, right? So the Taylor X trial divided patients into post and premenopausal based on age. It's slightly crude method, but stay with me. So what they found here was that for patients of greater than 50 years of age, if the score was greater than 25, right, the chance for recurrence was, so if the score was greater than 25, you require to give chemotherapy. But if it is less than 25, there was no improvement in recurrence rates with chemotherapy. But for less than 50 years of age, what they found was slightly different. So for score of up till 15, there was no benefit of chemotherapy. For 16 to 20 and 21 to 25, there was a 1.6% and 6.6. Yeah, a 6.6% decrease in the recurrence rate by adding chemotherapy. Now, it is not known whether it is chemotherapy that is causing that decrease in recurrence rate or if it is the ovarian function suppression caused by chemotherapy. So based on this, because we do not know whether chemotherapy is benefit or it's due to ovarian function suppression by chemotherapy, NCCN has said that for premenopausal patients, T1, T2, N0, based on the Taylor X trial, for scores of between 16 to 25, right, you can consider giving either chemotherapy or you can consider giving ovarian function suppression. So both are valid options. Now, coming to the Responder X trial for T1 to T3 and N1 disease, it was divided into pre and post menopausal. And what they found was that all premenopausal patients benefited from chemotherapy, especially if they had node positive. Whereas postmenopausal patients, chemotherapy benefit came for score greater than 25. So based on this, for T1, T2, T1 to T3 or N1 disease, you can consider giving chemotherapy. The score is greater than 25 for all postmenopausal patients. And for premenopausal, if it is node positive, you give it in all patients. If it is T1, T2, scores between 16 to 25, you can consider giving either chemotherapy or OFS. So that is why not all patients require chemotherapy in hormone positive, especially for early type of hormone positive breast cancer. Now, right. Now moving on to other factors here, right? So let's look at the chemotherapy protocols you can give for hormone positive breast cancer. So the best is dose dense AC followed by taxane, which has shown OS benefit in EBCTCG 2019 over 3-weekly AC followed by taxane, right? So that is the best option. The benefit is seen mostly in patients less than 50 years of age. That's where we give it. Now, if that cannot be given, especially if the patient is slightly elder and warrants chemotherapy, then you have to consider giving 3-weekly AC followed by taxane, right? Or you can give TC into 6 cycles. So these are other options for patients who are not fit for dose-dense chemotherapy, especially patients more than the age of 50 years, right? So here TC, of course, is docetaxel and cyclophosphamide, right? And just a clarification there. And we have data that's equivalent to AC followed by taxane based on the German Plan B trial and the ABC trials. Okay. So these are the chemotherapy options, ideally dose dense. If not, older patient, you can, and chemotherapy is warranted, then you might give these other agents. Now, what is the role of neoadjuvant hormone therapy, right? Neoadjuvant hormone therapy is given for patients who are not fit for chemotherapy, for elderly patients, for example, who cannot be resected upfront, who are not fit for chemotherapy. You can consider neoadjuvant hormone therapy. It is given with AI and is given for a period of 4 to 6 months. And there's something called the PEPI score, which PEPI, which looks at the response to hormone therapy, and PEPI score can also predict the recurrence rate post neoadjuvant hormone therapy. And a score of 0 predicts a low recurrence rate, while a score of 3 or 4 predicts a high recurrence rate, right? So that is neoadjuvant hormone therapy. That also needs to be kept in mind. Now, so I think that is it for hormone positive breast cancer. Um, I think we have covered all the various aspects of it. Um, Another thing to note in mind is that there's various good histologies, like I mentioned earlier, like mucinous, tubular, right, cribiform, where it's not as aggressive. So for T1 to T3 disease, you can omit chemotherapy, without any testing, right? And only if the patient is locally advanced with T4 disease, or if the patient has multiple nodes involved, there only you need to incorporate chemotherapy, right? But radiation is required. The rules for radiation remain the same even in those good histologies, but the rules for chemotherapy, there's a higher threshold only for locally advanced disease. Do we give chemotherapy in those particular histologies, right? So I think we've covered all the different aspects. Now, without further ado, let's move over to the next subset, which is triple negative breast cancer. So, triple negative breast cancer is treated mainly currently for all ages, whoever can tolerate it, by the Keynote 522 protocol, right? So, the Keynote 522 protocol has shown a IDFS benefit as well as a OS benefit, right? Overall survival benefit, and it is the standard of care in all ages who can tolerate it. So, what is this Keynote 522 protocol? It is a chemoimmunotherapy protocol. It consists of paclitaxel 80 milligram per meter square plus carboplatin AUC 1.5, and that is given weekly for 12 cycles. Following that, you give AC or EC into 4 cycles, 3 weekly. Following that, you do your surgery and you give radiation if required. And along with radiation, you can start off with pembrolizumab and you give that for 9 more cycles adjuvant, right? So this is the standard protocol for triple negative breast cancer. So Pacli plus carbo into 12 weekly, followed by AC, EC into 4. Along with that, you give Pembro, which is given at 200 milligram 3 weekly. Then you do your surgery, plus or minus RT, and you start off with Pembro once again. And you give that for 9 more cycles, right? And one more thing to note here is that you can give pembrolizumab with radiation, right? So that is to be kept in mind. You need not wait for the end of radiation. So Pembro into 9 cycles, right? Now, there are other adjuvant therapies that were previously approved in the pre-Keynote 522 era, right? So you've got, based on the CREAT-X trial, you have got the approval of adjuvant capecitabine, which is given for patients who have not attained a PCR post neoadjuvant chemotherapy, right? So for those patients, you will give 6 to 8 cycles, mostly 8 cycles if tolerated, of capecitabine, 1,250 milligram per meter square, day 1 to 14, every 21 days, and that's given for 8 cycles for the patients who have not attained PCR, right? So that is also another option. Another option is based on the Olympia trial. So patients who have received NACT, if no PCR attained, you can give olaparib 300 mg PD for 1 year. And patients who have received adjuvant therapy, right? So patients who have undergone upfront surgery, if they have PT2 or greater or N1 or greater disease, there also you can give 1 year of adjuvant olaparib. Now the question here comes, okay, what about in the Keynote 522 era? Can you also combine capecitabine and olaparib with pembrolizumab? Yes, you can. Although there is no randomized trial for this, but if the examiner asks you, you can mention that on an off-label basis, for patients who have not attained PCR on Keynote 522, you can consider adding your either olaparib, or you can consider adding capecitabine, right? Based on if there's a germline BRCA mutation, you add olaparib. If not, you add capecitabine. In a setting where PCR has not been attained, you can do that even with the Keynote 522 protocol in the adjuvant setting on an off-label basis. There's no randomized data, but you can do it on an off-label basis. So, moving on, what about patients who cannot afford pembrolizumab, as most of our patients cannot, right? So, in that scenario, you have got a TATA trial. So the TATA trial gave a slightly different protocol. It showed the benefit of adding carboplatin to your dose dense AC followed by taxane, right? So before I get into that, I'd like to just mention that for all TNBC patients with greater than or equal to T2 disease, that is 2 centimeters or more, you have to give neoadjuvant treatment, right? So that is a given. For patients who are less than T2, you can go for upfront surgery and consider giving adjuvant treatment in the form of dose-dense chemotherapy or carbopactly alone. But for most patients who present with T2 or more, you need to give neoadjuvant treatment. So that is one thing that I forgot to mention. So for patients who cannot afford Keynote 522, you've got something called the TATA protocol. This trial looked at the benefit of adding carboplatin to your dose-dense AC followed by dose-dense AC and taxane. So what it did in this trial was it gave a slightly higher dose of Pacli and carbo compared to the Keynote 522 protocol. So it gave 100 milligram per meter square of paclitaxel with a carboplatin AUC2 weekly for 8 weeks rather than 12, and it followed that up with AC or AC every 3 weekly, followed by surgery. So this trial was the first trial to show an EFS and OS benefit of adding carboplatin to dose-dense chemotherapy in in triple negative breast cancer. So this trial showed an OS benefit, whilst the previous trials with carboplatin showed only a PFS or a higher rates of PCR, right? So that is what you would add if you cannot afford pembrolizumab. Give carbopacli and ACEC. And we have the TATA trial, Indian data to prove that, right? The other trials were the Brightness trial, the CalGB trial, which also showed only EFS and PCR benefit, but this trial also showed OS benefit. Now, the OS benefit was restricted to patients with less than 50 years of age. So younger patients got that benefit. So what they're trying to hint at over here is that adding carboplatin might only show benefit in younger patients. So for older patients, you can still stick to your dose-dense AC followed by dose-dense taxane, right? So that is how you do it. Most patients, you give Keynote 522 protocol regardless of age if they can afford it. Whereas if not, you give carbopacli followed by AC or EC, especially for young patients. For older patients, there might not be much benefit of adding carboplatin, so you can give dose-dense AC followed by dose-dense taxane. So these are the various protocols for triple negative breast cancer. And of course, regardless of whether you're using Keynote 522 or a non-ICI protocol, you can give adjuvant capecitabine or olaparib if PCR has not been attained, right? So that is how you would manage this, a triple negative breast cancer case. Now, one point to note here is that, say, suppose the patient is allergic to paclitaxel, right? So if the patient is allergic to paclitaxel, then you can consider giving a substituent like nab-paclitaxel, right? So nab-paclitaxel is usually given at a dose of 125 milligram per meter square weekly. There are two trials for this, the JEPR-6 trial and the ETNA trial. The JEPR-6 trial showed a EFS benefit and an increased PCR rate, whereas the ETNA trial showed equivalence of nab-paclitaxel and paclitaxel. So for patients who cannot tolerate paclitaxel due to hypersensitivity, you can consider giving nab-paclitaxel as another option, right? Now, let's look at the PCR rates for these various regimens. So if you give dose-dense AC followed by dose-dense taxane, the PCR rate is around 45%. That will shoot up to above 50%, up to 55% if you add carboplatin. And with the Keynote 522 protocol, it is up to 64% by giving chemotherapy with carboplatin and ICI. So that is also a question that is asked. One more thing I'll discuss here is inflammatory breast cancer. When you're treating a case of inflammatory breast cancer, you should always give neoadjuvant chemotherapy first, right? Neoadjuvant treatment should be given first. You cannot go for upfront surgery. You should always do MRM because PCS is contraindicated. Adjuvant RT is always required, but you should never do reconstruction immediately in these cases, right? So these are all points that you need to look at when you're treating a case of inflammatory breast cancer, which majority of which are triple negative. Now, coming to the last section, it's HER2 positive breast cancer. So here, once again, all patients greater than T2 disease, that is greater than or equal to 2 centimeter, or node positive disease, you need to give neoadjuvant treatment. What is the treatment of choice? So treatment of choice is TCH into 6 cycles. So TCH into 6 cycles is a neoadjuvant treatment of choice, followed by surgery plus or minus RT. So TCH into 6 cycles, surgery plus or minus RT, right? And there are two scenarios here. If the patient, okay, so the patient has attained no PCR, you give TDM1 into 14 cycles. And if the patient has attained a PCR, you look at whether the patient was clinically node positive on presentation. There you give HP into 1 year, you complete 1 year of treatment, that is trastuzumab plus pertuzumab. If the patient was upfront clinically node negative, you give trastuzumab, you complete 1 year of total treatment, right? So this is the treatment protocol. Let's get into the TCHP regimen. So the TCHP regimen consists of trastuzumab, it consists of carboplatin, it consists of docetaxel, carboplatin, trastuzumab, and pertuzumab, right? So that is a TCHP regimen. So docetaxel is given at 75 milligram per meter square, carboplatin is given at AUC of 5, and trastuzumab is given at a loading dose of 8 milligram per kg, 3 weekly, followed by subsequent doses of 6 milligram per kg, and pertuzumab is given at a starting dose of 840 milligram, followed by subsequent doses of 420 milligram IV. Okay, so here the difference, you can, instead of giving H and P, that is trastuzumab and pertuzumab, as IV injections, you can also give it in subcutaneous form. It is available in the form of Phesgo. That consists of a combination dose of 1,200 milligram of pertuzumab plus 600 milligram of trastuzumab given as an 8-minute subcutaneous infusion, a subcutaneous injection, and subsequent doses consist of 600 milligram of both pertuzumab and trastuzumab as a subcutaneous injection given over 5 minutes, right? So initially 8 minutes and following that 5 minutes. So Phesgo is another option that can be given subcutaneously, saves a lot of time. Right. So you give your TCHP into 6 cycles. Earlier, we used to give anthracycline containing regimens, AC followed by taxane, combined with trastuzumab or pertuzumab. But we have now realized, based on the TRAIN-2 and the TRIFONA trial, that you can omit anthracyclines. There's an equivalency of giving TCHP with giving anthracycline-based regimens. And by omitting anthracyclines, you can decrease the cardiotoxicity and you can also decrease the secondary malignancies. So you do your surgery, you give RT, and you look at whether there's PCR, right? So if you give your chemotherapy alone, the PCR rate is around 40%. With trastuzumab, it is up to 45 to 50%, and with pertuzumab, it goes above 60 plus, right? So giving dual anti-HER2, currently we get PCR rates of 60 plus percent. So if the patient does not attain a PCR, based on the Catherine trial, which has shown EFS and OS benefit, you can give TDM1, which is an antibody drug conjugate that can be given at a dose of 3.6 milligram per kg over for 14 cycles, right? So now the side effects that, so one more thing about TDM1 is that you can give it with radiation. It is totally safe. The side effects include thrombocytopenia, liver dysfunction. It also causes neurotoxicity since it is a microtubule inhibitor. It can also cause allergic reactions. ILD is rare with TDM1, unlike TDXT, right? So if the patient has attained PCR but had clinically upfront node positive disease, based on the affinity trial, you can also add pertuzumab along with adjuvant trastuzumab. And if the patient had clinically upfront node negative disease, there might not be much benefit of adding pertuzumab if the patient has attained PCR. So we give trastuzumab alone for a total of 1 year, right? So that is the treatment protocol for HER2 positive disease. Now, currently there are some changes based on the DB11 trial. There's talk of adding TDXT, upfront. And based on the DB5 trial, there's talk of adding TDXT instead of TDM1, right? So that trial, the DB5 trial, looked at TDM1 versus TDXT in not all patients who did not attain PCR, but high-risk patients. So patients who had T4 disease upfront or N2 or N3 disease upfront, right? Those patients were considered for TDXT, and patients who had post-op node positive disease. So pathological node positive disease or upfront T4 or N2 or N3 disease, these patients were considered to be high risk and given TDXT. And in these high risk patients in DB5, it showed an IDFS benefit over TDM1. Okay, so TDXT, unlike TDM1, is given at a dose of 5.4 milligram per kg, and it is shown a benefit primarily because it has the bystander effect. So bystander effect due to a cleavable linker, and it's also got a higher drug to antibody ratio of 8:1 compared to TDM1's 3.5:1. So because of all these features, it has increased potency, and not only that, it has increased penetration beyond the blood-brain barrier, which has decreased the CNS mets as well. So for all these reasons, for high-risk patients who have not attained PCR, like I outlined earlier, you can consider TDXT. Although it is not FDA approved, it will soon be. So watch out for that, right? So that can also be asked in the exams as an advancement. So for disease that is T1B and T1C, right? So less than 2 centimeters, you have something called the APT protocol, right? APT protocol is basically weekly paclitaxel, 80 milligram per meter square, plus weekly trastuzumab, initially at loading dose of 4 milligram per meter square, 4 milligram per kg, followed by subsequent dose of 2 milligram per kg. And then once you complete 12 cycles of weekly paclitaxel, you switch over to 3 weekly trastuzumab for a total of 1 year. And that has shown, this is a single-arm phase 2 study which showed excellent IDFS of greater than 95%. So for smaller tumors greater than 0.5 to 2 centimeters in size, you can go for upfront surgery and then give APT protocol, right? For T1A disease, we do not know whether chemotherapy or trastuzumab adds any benefit. It is up for that question is not concretely answered yet. So we have discussed the management of all the different subtypes of breast cancer. I'd also like to add something in HER2 positive disease. Suppose the patient does not tolerate carboplatin, right? Has developed side effects, severe myelosuppression, or maybe towards, the patient was previously treated with a malignancy with carboplatin, and develops hypersensitivity, late onset hypersensitivity on retreating with carboplatin, or if the patient does not tolerate that treatment, then you can consider omitting carboplatin. We do have new data on that. You have the Helena 006 trial, the NeoCAR HP trial, both of which showed that omission of carboplatin is possible. Giving taxane with dual anti-HER2 has equivalent PCR rates. Although the long-term survival was not looked at, equivalent PCR rates are seen, and possibly, especially in patients who do not tolerate, you can omit carboplatins pretty safely. So we have data for that as well. Okay. Now, before we wind up, I'll just look at a couple of things, right? One of those is addressing the axilla. So we looked at axillary lymph node dissection, which was the standard of care, but now we have sentinel lymph node biopsy. So sentinel lymph node biopsy is done in clinically T1. Right. So it's done in clinically T1 and T2 disease, right? Node negative, right? Who are planned for upfront surgery, right? So these patients can undergo sentinel lymph node biopsy. So in your sentinel lymph node biopsy, if you get 1 or 2 positive nodes or micromets, you can still omit axillary lymph node dissection. We have extensive trial data in the form of ACOSOG Z11 trial. You also have the AUTOSORT trial and the AMAROS trial. All these trials have shown that even if you have 1 to 2 positive nodes or micrometastasis, only removing the central lymph node is enough, you can proceed with omitting axillary lymph node dissection. Of course, in all these trials, you had to give adjuvant radiation, especially to the axilla, to the supraclavicular fossa especially, and the axilla. So although you could omit ALND, you had to treat with radiation to compensate for that. But ALND omission is an option in SLNB patients with 1 to 2 nodes positive or micrometastasis, right? And SLNB is done usually with a dual radiotracer. You've got isosulfane blue, right? That is used, and or methylene blue, that is the dye, and you've got a radioactive tracer. Usually it's 99 technetium M, given at 0.5 millicurie, right? So both those are combined to increase the sensitivity and specificity. Now, one more thing I need to look at is omission of surgery of axilla. So you can omit SLNB, you can omit ALND if based on the sound trial. So the sound trial looked at T1, T2 disease with a clinically negative axilla, right? Where you do an ultrasound and rule out any malignant nodes, and then you can omit any form of axillary dissection, either SLNB or ALND. So although this is approved, it is not followed in most Indian centers, and you need only mention this if it is asked. Okay. Now, the third thing that I need to talk about is targeted axillary dissection. Targeted axillary dissection is usually done in triple negative and HER2 positive cases. Okay, so it is done in triple negative and HER2 positive cases, and these are patients who are planned for NACT. So you can possibly get away with omitting an ALND in certain cases of triple negative and HER2 positive breast cancer who receive neoadjuvant treatment. So what are those conditions? So not all patients can omit ALND, but if certain criteria are met, you can go for a targeted axillary dissection. So what are those criteria? You should tag the clinically involved node at baseline. So tag it with a wire, tag it with a tattoo, right? So the various methods, but you need to tag the clinically involved node at baseline. So this is for clinically node positive patients. So once you tag it, you then give your NACT, and you need to make sure that you have a clinically complete response in the axilla. So clinically, it should be YCN0. So post neoadjuvant treatment, there should be no node in the axilla. So that is the second criteria. Third criteria is you should use dual tracer SLNB. Single tracer is not enough. You need to use dual tracer SLNB. The fourth criteria is you should remove at least 3 sentinel lymph nodes, right? So those are all the criterias, and you do dissection by removing the tagged node as well as by doing SLNB and removing 3 nodes, right? So if all these criteria are met, you can get away with doing a targeted axillary dissection for patients who have received neoadjuvant chemotherapy who had upfront clinical node disease. Of course, if you detect any node in the tagged node or either in the central lymph node biopsy on pathological staining, you need to proceed with an ALND, right? So that is an option in clinically N1 positive disease, especially in triple negative and HER2 positive disease, who respond a lot to systemic therapy, right? So that's all. We have discussed hormone positive management, we've discussed triple negative management, discussed HER2 positive management of early breast cancer, including surgical aspects as well as the radiation aspects, adjuvant treatments, systemic therapy, etc. So I hope you understood all the different points. This is pretty much what they'll ask you in the exam. I don't think there's anything you can ask beyond this. We will talk about metastatic management in a subsequent class, which I will post before the current DRNB exam. So stay tuned for that. And have a great day. Hope you had a great session. Thank you very much.